So it all started, though, with peripheral use, and we're very fortunate to have Peter Sukas here, who's one of the world's highest volume and most knowledgeable experienced users of shockwave in the periphery. And so, Peter, why don't you tell us about your experience and the global experience, again, of lithotripsy in the periphery?
Yeah, thanks very much, Greg. So the IVL for the periphery has been around actually now for a few years, and there were several studies that have now been completed. Disrupt PAD1 and PAD were pre- and post-market studies, relatively small numbers of patients, but basically it was designed to demonstrate the safety and efficacy of IVL in the treatment of significantly calcified stenotic femoral popliteal vessels. And then Disrupt BTK, of course, was to evaluate safety and efficacy in the below-knee vessels, which we know are uniformly densely calcified greater than 75% of the time. But we do have now randomized data and prospective data in a real-world cohort. For example, in the Disrupt PAD study, this is an ongoing randomized trial that is comparing a strategy of IVL followed by DCB versus PTA and DCB, which has really become pretty much the standard of care for most patients with fem-pop disease. If we look at Disrupt 1 and 2 in combination, you can see that most of these patients, of course, were claudicants, but they had significant calcification. Now, in this particular analysis, calcification was based on the Yale Core Lab, which is radiopacities noted prior to contrast injection involving both sides of the arterial wall. But if you use the PARC criteria, about 87% of these patients were actually described as having severe calcification. And certainly in the Disrupt below knee study, again, we saw a very, very high preponderance of significant calcification. If we look at safety and efficacy, one of the things that we can immediately jumps out at you is the fact that there's an incredibly low incidence here of complications. There was only a single wire-induced dissection that required a stent, but other than that, there were no cases of distal embolization. There were no perforations or slow flow or no reflow. And this is so incredibly important when you're talking about patients with critical limb. If, for example, you have a patient who has a single vessel runoff and a bunch of tiny little geniculate collaterals, if you use orbital atherectomy or some other ablative technology, then you can potentially get distal embolization and turn that critical limb ischemia patient to an acute limb ischemia patient. So the fact that there have been no cases of distal embolization, I think, is remarkable and something that we're very happy to not have to deal with, because it can be a major limitation. And if we look at the 6-month follow-up data, there was freedom from TLR of nearly 97% of patients. And if you follow that up with the 12-month patency data and safety data, you can see that there were no additional safety endpoints between 6 months and 12 months, just speaking to the acute safety of this particular technology. We learned a couple of very valuable lessons, though, with regards to how to use the device. And probably the most important lesson is that you need to make sure that the device is not undersized. Just like with drug-coated balloon or any other technology, including stenting, you want to make sure that you're in contact with the endothelium, and we typically recommend a 1.1 to 1 ratio when sizing the balloon. And then the other important thing, of course, is to avoid therapeutic miss or geographic miss, and that's to make sure that you have the emitters that are overlapped by at least 1 centimeter, so that you can be assured that you're treating the entire segment of calcified vessel. This was especially evident in the post-hack analysis when we looked at the primary patency rates and freedom from TLR at 12 months. You can see there was a very statistically significant difference in terms of primary patency in those patients who were treated with optimal technique, optimal being defined as correct balloon sizing and avoiding therapeutic miss. You can see a difference between 55% versus 63% in terms of primary patency, but it really translates into a very impressive difference in terms of freedom from TLR, 73% versus 91%. Ongoing right now is the Disrupt 3 trial here in the United States. This is, again, a randomized trial, prospective study of over 400 patients at 60 global sites, and this is IVL followed by DCB versus a control arm of PTA followed by DCB, aiming for a target residual stenosis of less than 30%. We're also currently enrolling patients and have over 500 patients enrolled in the Disrupt PAD observational trial. This is a real-world study looking at the use of this technology in multiple different peripheral beds, and that includes aorta, iliac, common femoral, SFA, popliteal, as well as below the knee. We have found that particularly for common femoral disease, that this technology is especially useful in these so-called no-stent zones. It can really get a very nice result, and I would argue results that can rival those of surgical endarterectomy with a lot less morbidity and mortality. So it's important to know that the technology is evolving, and we traditionally have, until very recently, had the regular shockwave generator, which was able to elicit 180 pulses over 6 30-second cycles. But the new M5 generator is now able to deliver 300 pulses. And this is especially important not only from a throughput issue with the lab in terms of being able to get the cases done more quickly, but also from an economic standpoint. For most cases, you can get done what you need to get done with a single balloon, and that obviously is important in these times of cost constraint. The other important improvement, I think, is the fact that unlike the first generation device where there was more energy directed at the center emitter, you now have a more uniform distribution of that energy through all 5 of the emitters. And therefore, you're able to get more power over a broader length of lesion. And we know that this is especially important in the below-knee vessels where calcification is a really big problem. We've all had the experience that if you go back just 15 or 20 minutes later, you see this significant acute recoil, especially in these below-knee vessels. And so the ability to have a device that you can effectively deliver to the target site and be able to get a great and sustained acute result, I think, is incredibly important. Currently, the 3.5 and 4 millimeter devices, they're 40 millimeters in length. These are now recently become available. The 2.5 and the 3 millimeter devices will be coming out shortly. But the other advantage of the newer device is that it's 135 centimeter shaft length. So it gives you the ability to go up and over and treat distal tibial lesions as well. Mm-hmm. And it's also 5 French sheath compatible. So I'd like to just show a couple of very quick examples. This was a 91-year-old gentleman with multiple comorbidities who had developed several ulcers on his first, second, third, and fourth toes. He was seen at an outside hospital and was told there was nothing that could be done for him and that he was just going to have to get a below-knee amputation. Luckily, he came to us for a second opinion. And if you look at his baseline angiograms, you can see he's got pretty dense, significant calcific popliteal disease, and then all of his vessels below the knee are occluded. You can see the anterior tibia is occluded there just above the ankle. In this particular case, we treated the popliteal disease with a 6 millimeter IVL device, followed by a 6 millimeter DCB with a very nice acute angiographic result with no dissections, did not need to put any kind of bailout stent here, and then proceeded to work on the anterior tibial. And here we were able to use a 3.5 by 60 IVL balloon, treated most of the entire length of that anterior tibial, followed by a 3.5 by 210 millimeter balloon, and we're able to get a very nice acute angiographic result. But given the extent of his disease, we wanted to try to treat the posterior tibial to improve the outflow to the foot and heal those ulcers. Initial attempts to cross antegrade were unfortunately unsuccessful due to a subintimal wire path, so we performed an ultrasound-guided retrograde posterior tibial access, and then were able to cross retrograde, snared and exteriorized that wire, and then proceeded with using an S4 30 by 40 device to treat the posterior tibial, followed by a long low-pressure balloon with a very nice result there. And that residual disease in the TP trunk was treated with a drug-eluting stent. And if you look at the follow-up final angiograms, you can see a really lovely result with restoration of 2-vessel runoff to the foot. This is a patient that we actually just treated in a staged fashion yesterday, morbidly obese woman with obstructive sleep apnea, COPD, oxygen dependent, who presented with multiple ulcers of the right foot, both on the dorsum and on the lateral aspect in the heel. Obviously, this is multiple angiosomes involved here with critical limb ischemia. And much to our surprise, when we got initial access on the left, we found that she had occlusion of her common iliac artery with a flush occlusion there and severe bilateral iliac calcifications, performed right common femoral artery access, and you can see the severe calcification not only in the common femoral but also in the iliac vessels. We're able to cross that retrograde and then follow this up with IVL of both the right common and external iliac arteries in a similar fashion on the left, and then performed kissing covered stents for the bifurcation, followed by bilateral external iliac artery stents, and we're able to restore normal inflow into the legs, and then brought her back yesterday to treat this very, very high-grade focal subtotal common femoral lesion. She also had a subtotal right SFA lesion, was noted to have an incidental AV fistula there, but with 3-vessel runoff distally, which was a pleasant surprise. So we initially treated the common femoral with a 6.5 millimeter device, followed by a 7 millimeter drug-coated balloon with a very nice acute angiographic result. Again, no dissections or contrast extravasation here, followed by treatment of the SFA lesion with the 135 centimeter S4 device, and we're able to get a beautiful result just with the S4, but then proceeded with a 5 millimeter DCB to try to give her a better long-term result. And you can see we're able to restore 3-vessel runoff to the foot with a nice hot warm foot with return of palpable pulses, and I'm very optimistic that she'll go on to heal those ulcers.
Yeah.
It's great. Beautiful cases.
Beautiful case.
Congratulations.
Thank you.
So I think you've kind of, went over the range of possible applications for this technology, both in larger vessels, even at the ortoiliac bifurcation, down to the common femoral artery, the SFA, and now below the limb. So, Dean and I and other coronary interventionalists always describe peripheral intervention as a data-free zone. You have so many different options of ways to treat peripheral vessels, and it's great to see that you're starting to develop data to support the use of this devices. Of course, we don't have any comparative data yet. Shockwave is still relatively new, so we're going to ultimately need to generate that to determine which patients will benefit from lesion preparation, calcium modification. Basically, all we're trying to do is change the compliance, as you say, so then you can actually get your drug to the tissue. So in today's practice, how are you deciding which cases need lesion modification with a device such as Shockwave?
Well,
are you doing it angiographically? Are you using intravascular imaging? Are you trying without it and then defaulting to it if necessary? How are you deciding?
Well, it's really been something in motion, in flux. I mean, when we initially had our first experience with the technology, we were very, very selective and used it only for very severely calcified lesions where we knew from experience that we'd have difficulty crossing and getting an expansion of the artery. But once you start using the technology and you see what it's capable of doing, you can then, of course, expand that to other vascular beds and sort of broaden the indications. And it really has made a sea change in our approach to treating, especially femoral popliteal disease, because we're finding that we're using a lot less atherectomy devices. And we're also able to significantly reduce the amount of times where we have to put in a bailout stent. And so our default strategy for a lot of these calcified lesions is to proceed initially with IVL, followed up with a drug-coated balloon, and if we get a great result, we take the money and run and try to avoid leaving something behind if at all possible. And as I mentioned earlier, for below the knee, where atheroablative technologies can cause distal embolization, that has such devastating consequences for critical limb patients. So to be able to have something that can deal with calcium below the knee without risking embolization, I think is a major step forward. And so I suspect that we'll see a lot more use, now that the S4 is available, of this technology below the knee to try to get easy, consistent, and straightforward
So lower profile,
done.
more flexible, 4 emitters as opposed to 5 emitters.
Right.
And again, sizes will go down as low as 2.5
As low as
millimeters.
2.5.
Dean, you wanted to
No,
comment?
I think what's remarkable here in all these cases is the absence of high-pressure, non-compliant barotrauma from a balloon.
Right.
I mean, the reason you get these great-looking angiographic results is that you've had relatively low-pressure inflations, which we could never do before. So you obviate the risk for rupture, perforation, dissection all those things we've dealt with at 20 to 30 atmospheres has become maybe a thing of the past.
Right. A perforation below the knee can have devastating consequences, of course, because of the development of a compartment syndrome.
Right.
So the ability to do these procedures predictably and safely is a major step forward, I think.